Now,
Good evening, everyone, and thank you for joining us this evening. I am Pallavi Sharma on behalf of Hetero Healthcare. Welcome you all for webinar on post-COVID complication, management options, current and newer perspective. COVID-19 virus is continuously evolving and mutating. Not only it is affecting lungs, but it is causing various post-COVID complications. We at Hetero Healthcare have always been at forefront along with your side to fight against this deadly virus. This evening, our esteemed and experienced doctors will share their practical experience on the subject. Before proceeding further, do let me take privilege to introduce our moderator, Dr. Sitesh Roy. Dr. Sitesh Roy is a super specialist in allergy, asthma, and clinical immunology. Dr. Sitesh Roy is the founder of Dr. Roy Health Solution Multi-Speciality Clinic, Bandra, Mumbai. He has also been the former medical director of the esteemed Dr. Nifadkar's Asthma and Allergic Health Clinic, Dadar, Mumbai, as a senior consultant, allergist, immunologist, and asthma specialist. Prior to returning to his hometown of Mumbai in 2011, he was a senior consultant at the Columbia Asthma and Allergy Clinic in Vancouver, Washington, US, where he managed three busy clinics seeing both children and adults with variety of allergic, immunologic, and stress-induced disorders. Dr. Roy has also always been an associate vice professor of pediatrics and medicine at the University of MS Medical Center in Jackson, where he has served as a director of Jackson Medical Mall Allergy Immunology Clinic from 2002 to 2010. Dr. Roy received his Bachelor of Medicine and Bachelor of Surgery degree at the St. GS Medical College from the University of Bombay. He then completed a residency in pediatrics at the University of Illinois Hospital at Chicago in 2000. He went on to complete a fellowship in allergy and immunology at the National Jewish Medical and Research Center of the University of Colorado School of Medicine in Denver in 2002. Dr. Roy has authored a number of articles and publications for leading medical journals, as well as book chapter titled Stress and Allergic Diseases for the two-volume textbook of Psychoneuroimmunology, 4th edition. In addition to this, Dr. Roy has been a diplomat of the American Board of Allergy and Immunology, a conjoint board aggregated by the American Board of Pediatrics and the American Board of Internal Medicine. He is a fellow of American Academy of Pediatrics, the American Academy of Allergy, Asthma, and Immunology, and the American College of Allergy, Asthma, and Immunology. Dr. Roy was listed in Best Doctors in America from 2005 to 2010, and again in 2011 to 2012, as well as in the Guide to America's Top Physicians from 2005 to 2010. So I welcome Dr. Roy and invite him to take over the session. Over to you, Dr. Roy.
Thank you very much, Pallavi, for that very detailed introduction. I truly appreciate the healthcare team and all our panelists today for being here with us to share their expertise on such an important topic of post-COVID complications. Clearly something that we all have been dealing with for the last year and a half, and a really evolving and changing field that constantly has a lot that we have to learn from. And in that entire process, there is certainly things that we can share through these such forums that can really help us better manage our patients and give them the best possible care. Without further ado, our panelists for today, we have Dr. Sandeepa, an MD Chest, a DM Pulmonology, a consultant interventional pulmonologist, BGS Gleneagles Global Hospital in Bangalore, a board member, clinical research of the Institute of Pulmonary Medicine Research and Development. Dr. Sandeepa has 11 years of rich experience in respiratory medicines, working as a consultant pulmonologist in the Department of Pulmonary Medicine and Lung Transplant at BGS Global Hospital. Dr. Sandeepa holds several publications to his credit in various medical journals and scientific papers. He has proficiency in very unique advanced procedures, as have been listed here on your screens that you all can see. So a very warm welcome to Dr. Sandeepa. We also have Dr. Gauri Shankar Reddy with us. Dr. Gauri Shankar is currently working as a consultant and head MICU Intensive Care Department at BGS Global Hospital, Kengeri, Bengaluru. He also worked as a chief intensivist and assistant professor at the Basaveshwar Teaching and General Hospital, Mahadevappa, Rampur Medical College, Kalaburgi. As a consultant intensivist, he was also associated with the United Hospitals, a super specialty center for trauma and critical care, Kalaburgi. He's been awarded the life membership to the Indian Society of Anesthesiologists, Indian Society of Critical Care Medicine, and Indian Medical Association. So, a warm welcome to Dr. Gauri Shankar also. And we have Dr. Surya Narayana Sharma, who is a senior consultant neurologist and stroke specialist with the Apollo Hospitals. He's the founder secretary of the Karnataka Stroke Foundation. He was awarded second rank in DM neurology and RGU HS and 3 awards in the national level paper presentations. He is a co-investigator for 5 international trials, 23 publications, 6 chapters, and 22 conferences. His areas of interest include stroke, extracranial, transcranial Doppler, DBS in Parkinson's disease, demyelination disorders, and neuroinfections. So a warm welcome to Dr. Suryanarayan Sharma also. We're going to talk about coronaviruses, which are not new to us. They have been around, at least known to us, in our realm of microbiology since the 1960s, causing common colds during season changes, especially winter or rains. And then we had SARS-CoV in 2002, 2003, which really gave us the first idea of what this virus from the beta coronaviride family could do, followed by the MERS, the Middle East Respiratory Syndrome virus in 2011-12, and ultimately with the 2019 novel coronavirus, which is still with us as a global pandemic affecting over 200 countries and billions of people, millions of people so far. The SARS-CoV-2 virus is very different than the SARS virus, being about 25 times bigger in size, far more infectious, contagious, having transmission in the pre or asymptomatic phases also, and having 4 known variants of alpha, beta, gamma, and delta, which all have led to a greater contagiousness, transmission, transmissibility, infectivity, and ultimately manifestation of disease, as we shall be discussing today. We know that the entry of this virus through the angiotensin converting enzyme 2 receptors, which are largely identified in the respiratory tract type 2 alveolar cells in the lung, but also are present in the esophagus, upper and stratified epithelial cells, the ileum, the colon, the cholangiocytes, the myocardial cells, the kidney, the bladder, the olfactory bulb, the brain tissues, and through the neuropilin 1 receptors into various neurological centers in the body, suggesting why this widespread extension of this virus can cause so many issues. This is from a few days ago, but as you can see, the cases worldwide, India is still in second position, but given the rate at which cases are going and have been going even now at 30, 35, 40,000 cases per day, we are clearly going to be in the running for probably having the most cases in the world, provided we really keep up. As we can see, the vaccination schedule is progressing. We have the highest number of vaccines given. Still about only less than 10% of the population has 2 doses of the vaccines, and about 20 odd percent have had received both single dose, with around 43 crore doses being given already. The primary symptoms of COVID-19, as we all know, can begin by between day 2 to 14 after exposure. Average duration is 4 to 5 days, with runny nose, nasal congestion, cough, sore throat, fever, and then breathlessness being some of the primary symptoms, but fatigue, muscle ache, body ache, chills, headaches, nausea, vomiting, diarrhea. There can be a lot of differences in the presentation, with loss of taste and smell being quite unique to this virus and helping us identify it sometimes where other manifestations may be confusing. We recognize that ocular, cardiovascular, neurologic, psychiatric, and cutaneous in manifestations are also very much there, and there are people with low risk, high risk, especially with comorbidities that we shall be talking about. SARS-CoV-2 has been detected in saliva, respiratory, blood, urine, and stool samples. And as I mentioned, no organ in the body is really spared from this virus once it enters the body. At different stages in the disease, there are different therapies that will work. Stage 1, which is the early infection, is still the viral response phase. Mild constitutional symptoms, fever, cough, lymphopenia may be present. We also know things like the ferritin level, the LDH level can all start changing. The neutrophil lymphocyte ratios can start changing. As this progresses into the pulmonary phase, we start seeing shortness of breath with or without hypoxia. We can also at this point start noticing abnormal pulmonary imaging, HRCTs, transaminitis, low normal procalcitonin levels. And as the host inflammatory response picks up in this second phase and goes into the third phase, we then get into the acute respiratory distress syndrome with elevated markers, CRP, LDH, IL-6, D-dimer, ferritin, troponin, and many other changes. Some of the therapies that we have with favipiravir, remdesivir, dexamethasone, oxygen, which are well known, and we'll be discussing some of the more advanced treatments today, especially for some of the complications that we see. When we look at the long-term sequelae of COVID-19 from the past, we recognize that SARS and MERS both had impaired diffusion capacity for carbon monoxide and exercise capacity, which could last for 6 months after discharge. Things like PTSD, depression, anxiety were also fairly considerable after these syndromes. So in that sense, SARS-CoV-2 is behaving similarly, but the long COVID and the prolonged manifestations are worse when it comes to SARS-CoV-2 than it was for SARS. The pulmonary sequelae with diffuse alveolar damage that has been seen can also be combined with platelet fibrin thrombi, indicative of the coagulopathy that is seen in small arterial vessels of some patients. Hemophagocytosis and immune cell depletion are at the bottom of these kind of sequelae, which are also seen affecting other organ systems at the microscopic and macroscopic level, leading to the complications that we see. An interesting case when we are talking pulmonary, a 57-year-old female who has dry cough, no comorbidities, the HRCT showing no honeycombing or architectural distortion, that there are clearly changes that are noticed. There is mild restriction and significantly reduced DLCO, post-walk desaturation of 5%, distance covered 220 meters. 1 month later, without antifibrotic therapy, the patient is showing significant improvement in the HRCT, suggesting that in a large majority of cases, spontaneous resolution does occur naturally, but we recognize that there are cases that can be different. And the extrapulmonary manifestations of COVID, which we are going to focus on the neurologic with headache, dizziness, encephalopathy, Guillain-Barré, loss of smell, loss of taste, myalgia, strokes are something again that are very concerning. We'll also be focusing on the thromboembolism with the deep vein thrombosis, pulmonary embolism, catheter-related thrombosis, and many other manifestations that are there of extrapulmonary changes that are seen in COVID. And recognizing that some of these can come after the acute disease has passed in the following weeks, we have to be really vigilant about this virus and what it does to the body, especially in moderate to severe cases, but also in mild cases. When we talk about long COVID and neurology, brain fog, persistent loss of taste and smell, encephalopathy, and stroke are the big ones. There are obviously others that we shall hear from our panelists today. Pulmonary dyspnea, cough, chest pain, and the post-COVID ILD, which shall be one of our focus of discussion also today. We recognize that Parkinson's, dementia, depression, post-traumatic stress disorder, anxiety, neurologic and psychiatric sequelae are becoming more and more obvious in COVID-19 survivors, especially those with severe disease. Before going into our panel discussion, a message, you can call it, is a public interest message for our colleague doctors. Take care of your immunity, because if you're well, your patients are well. Remember, there's no better immune booster than fresh air, sunlight, a healthy diet, and exercise, and good sleep at night. If you are into yoga, pranayama, meditation, prayer, it makes a huge difference. Supplements when required and with guidance, and a positive attitude and mindset, because that's the only way we can beat this pandemic and take care of ourselves and our families. I shall now briefly discuss one case from which we shall start our discussion. A 57-year-old male with post-COVID infection, no known comorbidities, coming with breathlessness, dry cough, and gastritis. SpO2 of 94% on 4 liters of oxygen at rest, a heart rate of 80 per minute, BP of 130/90, bilateral crackles heard on examination, a CT pulmonary angiogram revealing mild dilatation of the pulmonary artery, mild pericardial effusion, no thromboembolism, fibrosis with traction bronchiectasis that is seen, 2D echo showing severe pulmonary hypertension with evidence for an elevated pressure and an RA-RV that's dilated with a thin pericardial rim effusion, severe restriction and severe reduction in diffusion capacity on spirometry, total lung capacity that's reduced, post-walk desaturation 9% into 60 meters of distance. The patient's CT scan, originally with a CT score of 16 out of 25, developed pneumothorax and pneumomediastinum during the infection, later on going to show pulmonary fibrosis with traction bronchiectasis and inter and intralobular septal thickening with mild dilatation of the pulmonary artery and no thromboembolism. And after starting antifibrotic therapy, certainly there are changes that are seen in the HRCT, and clearly the fibrosis with traction bronchiectasis and honeycombing becomes obvious, but the patient also starts showing improvement. So this is a classic case of post-COVID fibrosis with pulmonary hypertension. The treatment is mentioned here and can obviously change as per the physicians and the treating physicians, and we shall learn more about it. But with this, I shall sharing one case where a person resolves on their own and one where they required a lot of help to resolve. I shall now begin our discussion, and the first question that I would like to pose to is to Dr. Sandeepa. Dr. Sandeepa, in your experience, have you seen differences in the manifestations of COVID-19 as a virus between the first wave and the second wave? And if so, what have those been, and what has been similar and what has been different? Dr. Sandeepa, has he joined us?
Not yet, sir.
Oh, you said not yet?
Yes, sir.
Okay. In that case, I shall take the question to Dr. Gauri Shankar. And would you like to give some insights for our audiences into what have been the differences in the first wave and the second wave that you have observed? And what are some of the red flags or concerns that you see for patients who go on to have severe or critical COVID?
Good evening, Dr. Roy and everyone. So, taking on your first question, before that, a very well presentation and a brief about COVID-19 that you gave. So, compared to the COVID first wave and second wave, what we could see was that obviously the age limitation which was there in the first wave to say around above 55 age was no more seen in COVID-2. The severe illness was also seen in younger age groups. Though we could see a few cases with comorbidities like asthma who went to severity requiring ICU in age groups of around 20 to 30 years. But that was, anecdote, 1 or 2 cases in first wave. But in second wave, we had a lot of young patients coming in with severe illness and surprisingly with no comorbidities. Secondly, the presentations in first wave, we were seeing that they would deteriorate in first week and they would present abruptly with high-grade fevers, breathlessness, severe hypoxia, and presenting us with a few thromboembolic events also, unexplained features of myocardial infarction. But in second wave, we saw more of late presentation. By late presentation, I mean arbitrarily somewhere in the second week or late second week. And it was more of pulmonary related complications, mostly hypoxia and refractory respiratory failures. And coming back to the red flag signs, yeah, there was not much difference in previous first wave and the second wave. But yeah, in general, when we look at the red flag signs, I would generally like to classify them into red flag signs that would be related to history, then symptomatology, and then the lab investigations. So whenever a patient has the history of, say, comorbidities like lung problems of COPD or some already fibrosis diseases, or they have chronic, moderate to severe asthma, or hypertension, metabolic diseases like diabetes mellitus, or severe obesity, or obesity for that matter, BMI of more than 30, and patients with immunodeficient states like some carcinomas, hematologic disorders like sickle cell anemia, organ transplants, CKD patients, and patients with some vasculitis disorders. So these are all the red flag signs in the history which we have to catch, which will help us to recognize the severity. Secondly, when it comes to a presentation with high-grade fever or presentation with features of severe hypoxia, they're all red flag signs. And if you look at laboratory parameters, everybody, like it's known that high D-dimers and CRP are related to severe diseases, but also specifically we have to look at lymphocytopenia, lymphopenia, the neutrophil lymphocyte ratio if it's more than 2. Then thrombocytopenia has been associated with increased mortality. Coming down to electrolyte abnormalities, interestingly, hypernatremia. We have seen a case, we have seen ourselves in our ICU, couple of cases, and when we looked into the data, we found that case series published showing that hypernatremia, unexplained, is also another red flag sign for severe disease. Then coming down to features of acute renal failure or ALF, they present with at presentation. That is also red flag signs. And obviously, the lung involvement in the CT would also help us to be, more, to see the severity, we are more attention towards the patients. So that's all, yeah, to summarize. Yeah.
Okay, thank you. I think that's a good summary. And I think one of the features that a lot of us observed, and I'm sure you all did too, was prolonged fever in the second wave. We were not seeing fever into day 8, 9, 10, 11. And this was a very common feature, especially for the cases that were moderate to severe. And I think that was a very different presentation, and it was just a sign of the degree of inflammation and hyperinflammatory state that this virus was inducing, and very often that was associated with a worse prognosis in some cases. Dr. Sandeepa, thanks for joining with us.
Actually, I'm extremely sorry. I'm extremely sorry for being late.
Okay, that's okay. We are happy to have you with us.
Monday evening, actually, a bit busy in the clinic. Colleague is also not there. Sorry for the late joining.
I'm actually going to get you right into the discussion and ask the next question to you. We were talking about the HRCT and the role of HRCT in the early evaluation. What I would like to direct to you is, there have been a lot of what I would call use and misuse of the HRCT. So can you give your highlights onto what is the right timing to do the HRCT, and how do the appearances or differences in appearances of the HRCT give us an idea about how the patient is doing, who's at risk, who will need further workup, who may need a repeat HRCT later. So just a little bit on the HRCT and its role in this entire disease and its evaluation.
Yeah, actually, it's a very good question. As you said, I think, it has been overused, misused in this particular pandemic. See, what we have to understand as a treating physicians is HRCT is a diagnostic modality, and it is not going to, what to say, give any kind of treatment to the patient. That is the first. It is a diagnostic modality. So when do you use a diagnostic modality? Whenever a treating physician is in a diagnostic dilemma. When we have a diagnostic dilemma, then it makes a point for all of us to ask for an HRCT. Okay. Initial days means I'm talking about the first wave. Okay. First wave, we were not sure whether the patient is real. Patient has got a symptom suggestive of COVID, and the RT-PCR turns out to be negative. And at that juncture, it will be difficult for the treating physician also to get himself convinced, as well as to convince the patient also. In such a situation, whenever there was a diagnostic dilemma, it is a point to ask for an HRCT so that we see certain features like ground glassing, peripheral predominance, more of a basal involvement, this classical picture of COVID-19 pneumonia. Okay. Otherwise, I don't see when a patient has got a classical anosmia, fever, and all those things, we are at the peak of the pandemic. And even if it is RT-PCR negative, as a treating pulmonologist, I am doubly sure that I am dealing with COVID-19. Okay. And that has made me stop at that juncture. If you ask me, Dr. Satish, see, the thing is, out of 3,000 to 5,000 patients we have treated over the last 1.5 to 2 years. Okay. I have personally written less than 10 CT scans as a treating pulmonologist, because the need for a HRCT scan in a case which is clinically fitting into COVID is very, 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 very minimal. Okay. So to sum it up, so whenever I have got a diagnostic dilemma, I would like to get an HRCT. And mind you, I'm telling you, scoring is not to be relied upon, because the picture of COVID keeps on changing day by day. Maybe every 12 hours it keeps changing. What score is there on day 5 might not be there on day 7, and it might worsen further by the end of day 10. We cannot go on repeating CT scans. So the usage of CT scan is very, 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 very minimal in COVID-19 pneumonia. So as treating physicians, this is a new disease, and for all new diseases, it is the clinical syndrome which is very important as compared to the diagnostic modalities. See, forget about urban areas. See, urban areas, we have got facilities at least. In semi-urban areas, in taluk places, you ask for a CT scan, and ready that fellow is searching for an ambulance, searching for places to go get himself, the scan done and coming back. That will unnecessarily cause the wastage of time. And in COVID, time is everything. You have to identify the cases early. Just simple oxygen saturation monitoring every 8 hourly after walking for 5 minutes will serve all the purposes which a CT scan has to serve. And again, CT scan is one time. This is a dynamic monitoring. So the role of CT scan is very, very minimal. Unnecessary usage of CT scan has to be stopped. And again, it can be ordered only when the treating physician has a diagnostic dilemma, not to score, not to prognosticate, not to do anything other than diagnosing COVID.
Your point is very well taken, Dr. Sandeep. I think you were very emphatic about the overuse of CT scans, and I clearly have seen that in my own experiences, where people on day 2 or 3 have gotten a CT scan. The CT scan has been negative. They have thought that they are safe, and by day 7 or 8, they have precipitously worsened. Because they were not taking care of themselves. And when the scan was repeated at that point of time, it was much worse. And there have been people who have had a negative RT-PCR more than once and had a positive CT scan, which has helped at least narrow the differential and the diagnosis down. But again, that can be done even without the CT scan, as you
Yes,
rightly said,
yes.
without exposing to the radiation and everything else that it causes. But I think that in some cases, where if it is done between day 5 to 10, which is typically when the changes start occurring, I think there may be some role, especially in cases that we are concerned are going to get worse over time. And we shall also come a little bit later and talk about whether a repeat scan can help us in knowing about the future, about the fibrotic diseases that can develop in the lungs of these patients. So switching gears a little bit, I shall now come to Dr. Surya Narayana, who has been very patiently listening to us so far. Uh, the question I have for you is, as a neurologist, we have spoken about the many different ways by which the virus can get into the nervous system and get into many parts of the nervous system. What are some of the common and uncommon neurological manifestations that you have seen of COVID-19 during this pandemic, whether it be the first wave or the second wave?
Yeah, good evening. Am I audible?
Yes, you are.
Yeah, good evening. Thanks, Hetero Healthcare, and thank you, Dr. Sitesh, for inviting me as a panelist. At the first, we have seen various neurological complications both in first and second wave. If you see first wave, we had a lot of strokes. Actually, we have come across a lot of thrombotic strokes. At least my team has seen at least 40 strokes in first 7 months of pandemic, from April to November. Though numbers dropped down, but in second wave we had a very less number of acute strokes in COVID, thanks to the early use of anticoagulation. Definitely that has changed. That's a game changer, especially in acute stroke, I would say. We have done even thrombolysis, endovascular intervention, decompression craniotomy in COVID patients, and COVID outcomes have been very good actually. Even I had two of my staff who had COVID with stroke actually. One more staff, her husband was positive with COVID. She was not having COVID that time. She was tested negative. 1 month later, she had stroke. But that time we did the inflammatory markers. It was high. Antibody levels were in 6,000. So again, it was favoring. We did a thrombophilia workup that was negative. So again, that was favoring. Possibly she was asymptomatic COVID, and post COVID she had a stroke. So that is about stroke. We had seen CVTs, cerebral venous thrombosis. We had seen even a press-like presentation that we call it as a demyelination, CNS demyelination. GB syndromes. First wave, we had seen quite a number of GB syndromes. Second wave, fortunately, it was lesser. Then headache was one of the commonest presentation. A lot of our migraine patients used to come back with worsening of headache, no fever, nothing else. You ask them to do a COVID rapid, it is positive. Treat them with, treat them symptomatically for COVID. Within 3 to 5 days, their symptoms subside. So that is about headache. We had seen neuropathies, post-COVID neuropathies. A lot of patients have, especially when they have gone into ventilator, ICU care and all. We had seen a lot of patients, coming back with critical illness neuropathy or nutritional neuropathies. So that is one thing. I have seen 2 cases of myasthenia gravis post-COVID, but difficult to say what is the exact, connection or cause-effect relationship. That is one thing. Mucor, yes, we have lost quite a few patients with mucor. We have seen mucor with brain abscess. We had 3 patients. We had aneurysms with bleed. We had 1 patient with aneurysm and bleed. We had a lot of patients with cerebritis, that is focal brain inflammation with mucor. So this is the variety of presentation what we had seen. Regarding Parkinsonism, what you had been describing, usually what happens is this is common in patients who are in ICU for a longer time, who are on ventilator, or who had fluctuation in their oxygen levels. So basal ganglia being one of the most sensitive organ in the sensitive part of the brain. After cerebellum, basal ganglia is second important area of the brain, which has a very high metabolism rate. So it is, it will get affected. So many a time we have done an MRI in patients. So they present Parkinsonism-like feature. So what we used to see earlier with prolonged CABG, wherein they never used bypass machines, off pump So they used to have a lot of brain hypoxia. This is in a nutshell about some of the common neurological manifestation what we have seen in COVID.
Thank you. I think that's a very good overview. I know we've heard about things like Bell's palsy and those things also present in this post-COVID scenario. So clearly, as we can see, manifestations during the illness, manifestations after the illness, manifestations for up to a month or two after the illness, where some of these strokes, etc., have presented, suggesting that the inflammatory and the coagulopathic situation that we deal with is a prolonged issue lasting several months. And clearly the direct damage to the nervous system is also there, because we all know about the people who have prolonged loss of taste and smell taking months to come back. So thank you very much. My next question again is to Dr. Gauri Shankar. Dr. Gauri Shankar, what I would like to ask you is, when we look at the complications that patients who are entering in with severe and critical COVID-19 are entering into the ICU or the MICU, what are some of the complications that you all have had to deal with in these patients with severe or critical COVID? So what kind of issues are there that you all see?
The most common issue with which they would get admitted to ICU was obviously hypoxia. It was respiratory failure, ARDS basically. So almost 30 to 40% of mortality is also attributed to the respiratory failure and severe ARDS. It would be generally the second week where patients are shifted from ward with high requirement of oxygen. Other pulmonary complications they would come with was pneumothorax, severe pneumomediastinum, and difficulty in breathing, even though there was no hypoxia sometimes. Then coming down to cardiovascular complications that they came was with acute MIs. The most common that has been seen in the data is arrhythmias, SVT, sometimes VT, and QTC prolongation. We have seen a lot of bradycardias, few QTC prolongations, and some features of angina and ischemia. Stress-induced cardiomyopathy like features with reduced EF, global hypokinesia, patients coming with heart failures. Then patients have also come with septic shock-like features, right? Then there have been coagulation abnormalities, severe thrombocytopenia, and patients have come with few features of DIC also. We have also seen patients coming with around, even the data suggests acute kidney injuries and liver failure, acute liver failure. Not many, but a couple of cases. Then there have been one case, pancreatic injury, not attributed to anything, probably COVID, because he had COVID positive and lot of high-grade fevers, young patient with no history of alcohol or other things. And we have also seen patients with uncontrolled sugar coming up on steroid therapy, presenting like features of ketoacidosis. And obviously neurological complications that are enumerated. Mainly it was a stroke and a few bleeding, IC bleed cases also. Yeah.
So you have so nicely given us an overview of all the issues that you all have seen. Would you say that the root of this, obviously two issues, primary issues are there. One, their lungs are not working right, and two, there are multiple organs in which there is blood circulation issue, which means there are microthrombi, microclots occurring, whether it's the pancreas getting affected, the liver, the kidney, the brain. So I think at the root of it, I think it's the lung and the bleeding, the blood circulation issues that this disease creates. Like you say, the patient with the prolonged fever, they get dehydrated, they have more coagulopathic issues. Combining all that together, they end up with organ damage or organ failure, whichever one gets involved, whichever is the weakest link for them in that situation. So I think that that's a very good overview. Dr. Sandeep, I would like to come to you with the next question. And we've spoken about these patients who post-COVID are at risk for developing pulmonary fibrosis, or what has even been called COVID ILD, if I may call it that way. So, in your opinion, what are some of the risk factors, or what are some of the red flags that our audiences can focus on or recognize that this may be someone who is going to go on to have long-term issues with their lungs, and they really need more careful monitoring, maybe a high resolution CT scan before discharge from the ICU or from the hospital, depending on what their course has been. So, are there certain risk factors, certain investigation related factors that can help our audiences identify a post-COVID lung fibrosis so that they can better manage it with timely interventions where needed?
Actually, it's a very good question. Interesting question also. See, the thing is, although there has been much talked about regarding the post-COVID fibrosis since the beginning of this particular pandemic, see, there are hardly any patients with fibrous lungs who are following up with us out of 3,500 to 4,000 patients whom we have treated. Maybe 1, 2, or maybe 3 or 4 who are still requiring oxygen. Rest of them, even though they were in ICU, even though their hypoxia was severe, even though the extent of lung involvement on the CT scan was severe. Okay, most of them. Recently, I had I went through one study also, which has clearly told most of the people will have a near normal CT scan at the end of 6 months post-COVID recovery. Okay, so now the discussion regarding this post-COVID fibrosis itself becomes very interesting at this juncture, because the thing is, the way it has been hyped about, the way it has been thought about, okay, at the beginning of this pandemic, is not really experienced by the treating pulmonologists. I don't know about the other people. At least in my experience, around 4,000 cases under our belt. Okay, in our experience, in our center's experience, as well as in my private practice. See, we have treated so many patients, but most of them will eventually recover back to their normalcy over a period of time. Okay, how long are you going to wait is again a question. As a patient treating physician, it is our bound responsibility to wait till the patient recovers, rather than interfering or rather than meddling too many things around with his lungs or around with his health is not a right thing, is what I would personally feel. So the incidence of post-COVID fibrosis is extremely less. Okay, so every injury in the body is known to heal with fibrosis, no doubt about it. Okay, to what extent that fibrosis is causing the gas exchange abnormality is the question which we have to sit and answer. Even if the 30% of the lung is involved and it is showing fibrosis, and that person is able to walk for 5 kilometers without getting compromised on his oxygen saturation, I am not bothered about treating that fibrosis, because I know that it is a one-time insult. So COVID infection comes, it injures and it goes. See, comparing COVID fibrosis with that of an interstitial pulmonary fibrosis or a non-specific interstitial pneumonia kind of a picture, or for that matter, hypersensitivity pneumonitis, is first of all not a right thing to do, because there the injury is ongoing. So every day, every hour, every month, the injury is going on, and that is the body is responding by fibrosing. But here, COVID is a one-time injury. Okay, it has affected a certain extent of lung, and it goes away. And whatever extent of the lung has been damaged will eventually get healed by fibrosis. Okay, and over a period of time, I am sure, I think most of the pulmonologists would agree, right? Because we have seen one whole lung getting fibrosed because of tuberculosis. We never thought of post-tuberculosis fibrosis as something which is big, because we knew that even if it is a fibrosis of one lung, the other lung will hyperinflate and eventually what to say, or it will what to say, hyperinflate itself to meet the needs of that particular individual. Okay, so definitely the incidence of post-COVID fibrosis is extremely low. Okay. And in people, in who are the people whom we should be careful about? If that is the question, again, see, the male sex is most commonly affected. The people with initial severe injury, the people who land up in the ICU before the beginning of this inflammatory phase. Okay, so who land up in the ICU with hypoxia, with a saturation of 50 or 60 within 3-4 days of their disease. That means because of the virus itself, if they get affected, I think they are the ones whom we should carefully monitor for fibrosis. The third thing is, the larger the extent of lung injury, or the larger the extent of lung involvement on the CT scan, they are the ones who have to be monitored. Again, monitoring, I would not suggest CT scan at all, even at the time of discharge. Why should we need? Why we need it? When the patient, you are discharging a patient with a normal saturation, and each and everybody knows radiological resolution lags the clinical resolution by at least 6 to 12 weeks. I think that's what, again, emphasizing on the need for CT scan at the time of discharge. I personally feel, as a pulmonologist, I don't vouch for any kind of repeat CT scan, at least for a period of 3 months from the date of admission. Okay, you examine your patient at the end of 3 months. If you still feel that the patient is hypoxic, if you still feel that the patient is not improving at the rate of your expectation, maybe at that time you can consider one repetition of the CT scan, just to look at the extent of the, injury and extent of involvement. Okay. And again, so basic teaching goes, as long as there are ground glass opacities on the CT scan, presence of ground glass opacities is an indication for steroid. Okay, that means it is a steroid responsive condition. Okay, so steroids should always be continued. Okay, till the patient, at least for a period of 3 months, if he is not recovering from hypoxia. Okay, and maybe at the end of 3 months, you do a CT scan. If you see an organizing pneumonia, you are justified in continuing steroids. Or if you see fibrotic strands, I think that is the time when you should label it as a post-COVID fibrosis. Not before 3 months is what is my personal opinion.
So I think, Dr. Sandeepa, I've done about 4 of these seminars before, and it's interesting to hear your experience. 4,000 patients is a lot of patients, but I've had other pulmonologists who have said that if the patient has had a very rocky course in the hospital with a lot of ups and downs, a lot of prolonged dependency on the ventilator, they've had what is called a more dense consolidation versus the ground glass opacity appearance. If they've started to show changes, if they are getting discharged, and at discharge they're still requiring 2-3 liters of oxygen to maintain their saturation, then in all of these situations it becomes necessary to know. Because as you rightly said, I agree with you, 85% of people are not going to need anything. But there may be 10 or 15% people that we may miss if we do not do this evaluation. Now, if it happens so that those people don't have those changes, I'm sure it won't matter. But if they are requiring these things, because the general opinion that I have heard from other pulmonologists is that if you've had a tough hospital course, you have these changes on the CT, you have a person who's still requiring oxygen, you have a person who you feel is not really up to the mark at the end of 4 weeks of a hospital stay or 5 weeks of a hospital stay. These people, because I completely agree with you, it's a one-time insult. But it is also known that when we look at the therapies that are there for these treatments, if you miss the initial stage when the fibrosis is still developing, when these medicines may work the best, you may then have missed the bus where you can go in and make a difference in the disease. So I think we'll come back to this discussion in the next question that I ask you. And I think we have some interesting audience questions also coming up related to exactly what you're saying. But your point is very well taken again, that it's overdone and it may be unnecessary. And there may be some situations in which where it needs to be done. But in others where it may be unnecessary and it may create more panic and fear.
Yeah, that is what it is doing. That is what it is doing. It is creating more panic than benefit. That is my point.
Absolutely. Dr. Suryanarayana, I will come to you now with the next question. You've mentioned strokes that occur in people with COVID-19, and this obviously, stroke happens to be one of the most serious complications because it can leave a person with a lifetime of deficit sometimes. So are there, in terms of the types of strokes that are seen in COVID-19, is there any difference from what we normally see with other causes? And do you believe that the management of those strokes is different from what you would routinely manage? And if so, what are the points or what are the red flags or what are the features that you may say? So the types of strokes, the management of the strokes, the difference of management compared to routine strokes, if you can just highlight for our audiences.
Yeah, basically COVID causes what is called a thromboinflammation. It causes inflammation of the blood vessels, endothelial dysfunction, and following that there will be microthrombi formation, and basically it causes a hypercoagulable state kind of presentation. So what we have seen is ischemic stroke is much commoner than hemorrhagic stroke, number one. Bleeds we have seen because usually the bleed patients, they'll have associated axillary hypertension, autonomic dysfunction, and other things. We have seen 1 or 2 cases of subdural hematomas and cerebral venous thrombosis. Basically, these 3 major subtypes of stroke we have seen. It is said that COVID increases the stroke risk by 7-fold as compared to a non-COVID person. So that is the usual risk what we have noticed. And regarding the management part of the COVID with stroke or stroke without COVID, the treatment guidelines doesn't change much. Only problem is having a barrier, barrier care or keeping healthcare workers' safety was a big concern in the initial first wave. But soon we overcame, that part actually. Because running the COVID test, and after that administering thrombolytic agent and all that was a big task, especially in the first month. And subsequently, when we started having a separate stroke pathway for these COVID patients, the risk actually drastically reduced. And especially operating these patients, whether patient had a subdural hematoma or intraparenchymal hematoma requiring evacuation. Initially, we had lost 1 or 2 patients because their the coagulation tendency was unpredictable, I would say. But after that, actually, with the administration of FFPs, with judicious use of antiplatelets and other things, I can say in 2021 we had 0 mortality in stroke care. That is for this one. So and following after discharge, usually if we identify any other risk factor apart from COVID, the treatment guideline doesn't change. But if there is a COVID with stroke without any obvious other risk factor, usually we start them on anticoagulation for minimum 3 months. Minimum 3 months. After that, we reassess these patients. We do the inflammatory markers, and generally, we take a call at the end of 3 months. So anticoagulation is a big, difference, especially in COVID with stroke versus COVID versus stroke without COVID. Stroke without COVID, we have standard, SOPs. If there is a cardioembolic stroke, this is what you do. If there is a large vessel occlusion, if there is small vessel disease, stroke of determined etiology, there are standard guidelines. We follow that. But COVID with stroke, we anticoagulate them at least for 3 months.
Thank you very much. I think that's the message that you gave, 7 times more likely with COVID.
Yes.
Stroke. I think that's a very big and important feature, and I think all our audiences need to be aware of that. Since we are on the topic of anticoagulation, I might as well ask you the next question in terms of choice of anticoagulation in hospital, outside of hospital. What are your preferred molecules? You've already said that 3 months is the duration that it's recommended, and I think most people agree with that. So do you prefer to go with the low molecular weight heparins? Do you prefer to go with some of the newer agents? What has been your approach?
To start with, we start them on low molecular weight heparin, LMWH. If there is a bleeding risk which is higher, then we start with heparin, plain heparin, because reversal is quite easier for us. If there is a renal dysfunction, again, we go for a plain heparin. But if they don't have all these, then we start with low molecular heparin. And we have been using NOACs, the newer oral anticoagulants, quite widely. We have used even azithromycin and warfarin in some patients, but again, follow up and all is a problem actually. Many a times, many people, even after discharge, they don't want to come to hospital for very frequently, or they don't want to get their bloods tested very frequently, because that again is a risk for the healthcare worker. Even they will be in the quarantine period also in that time actually. So we start them on NOACs. All three NOACs we have used: dabigatran, apixaban, rivaroxaban. Dabigatran, especially if the renal function is normal, we have used in quite a good number of patients. Apixaban and rivaroxaban also. Rivaroxaban, one good thing is about OD dosage we can safely give in once a day dosage. So 2 doses we can avoid, and even renal creat clearance we can match and we can use it. Only thing is, what we have seen as per the literature says that there is a mildly increased bleeding risk with rivaroxaban, but in our personal experience, all three molecules we have used, and except for renal dysfunction, all three molecules have fared better. They have given good results, and after 3 months, yes, if it's a low risk case, if the inflammatory markers have settled down, we take a individualistic decision on each individual patient. As I was telling about one of our staff, radiation oncology technician, who had COVID, like her husband had COVID and stroke, and we have just stopped anticoagulation 2 days back for her.
Got it. Thank you. I think that's a good approach that you have given to our audiences, and that will be greatly appreciated. Dr. Gauri Shankar, I'll come to you with the next question. In your opinion, what are some of the risk factors that put a person at risk for developing post-COVID fibrosis, and is there a benefit to initiating some treatment in order to prevent the progression of post-COVID fibrosis? And are there any medications or interventions that, in your opinion, can be of benefit in these cases?
Yeah, as Dr. Sandeep enumerated, fibrosis is a way of healing. So as there is injury, it heals with fibrosis. And when we say that, so the duration of the injury and the severity of the injury of the lung is one of the major determinant for further fibrosis. When I say that, if acute phase of lung injury lasts for say around more than 1 to 2 weeks, then there has been a higher incidence of fibrosis found. It may not be crippling, though, that they might need long-term oxygen therapy, but some amount of fibrosis is seen. But in our experience, we have seen few patients compared to non-COVID ARDSs requiring home oxygen therapies and oxygen concentrators. So I would see it in a way that, because the COVID is inflammatory and thrombotic cause for the fibrosis happening, there are various growth factors activated, fibroblast activity going on, intravascular thrombosis happening, diffuse alveolar damage happening. And there is also some amount of lung injury caused by therapeutic measures like ventilator-induced lung injuries there. Even the oxygen is thought to be a fibrotic agent. It can cause fibrosis, some amount of hyperoxia. So all these reasons, causes are attributed for the incidence of whatever low or high, the incidence of fibrosis happening over there. So there were initially, even we have used thoughts of using these anti-fibrotic agents, whatever like pirfenidone or nintedanib, to mitigate or reduce the after effects that could happen due to fibrosis. So generally we used to start early whenever the patient comes to ICU requiring oxygen therapy and having ARDS, moderate to severe category, contemplating the lung injury has already set in. So we have used pirfenidone initially, then switched on to nintedanib. But when I look at the evidence, there is as such no robust evidence as of now that I could lean to, but there have been few studies, Japanese studies, Egyptian studies, and the underlying mechanism that the antifibrotic agents interfere with tyrosine kinase inhibitor, like the nintedanib, and their efficacy in reducing the conventional IPF burden on the lung, improving the FVCs. So there has been some evidence in IPF. The same has been contemplated to be useful in the COVID-19. But I think still there has to be a lot of robust evidence awaited. But when it comes to high-risk patients, like who have had a very severe acute phase, patients with comorbidities, lung comorbidities already having, and patients who have limited lung reserve, where we do not want the remaining vital lung to get fibrosed and cripple them. Probably they're selected cases, and it's left to the treating physician to use these drugs. But that's my overview.
In your opinion, Dr. Gauri Shankar, if you look at all the cases that you have seen or heard or been a part of the management, what percentage of patients that you are handling through the ICU or through severe or critical COVID would you say that require antifibrotic therapy? What has been your experience of using, like, do you put most of your patients who've had a rough course, required ventilation, required, had changes on the CT, are most of them going home with an antifibrotic agent, or are you selective? And would you say the number in terms of percentage, just a ballpark, your own experience? I know data is mixed, opinions are mixed, thoughts are mixed, but I think our audiences really want to know from all of us as experts what is our experience.
Yes. So when it comes to ICU, I know most of my patients have ARDS, moderate to severe ARDS, and the higher likelihood of them having some fibrosis. So initially we do start them with antifibrotic agents, but looking at the recovery, the way they recover, we might as well opt out for few if they are having good recovery. For few who might continue to worsen or to have a prolonged disease process, we tend to continue on few antifibrotic agents. Again, to establish that they had fibrosis or not, we might require CT scans. We might have to wait for 1 to 3 months, sometimes more. So to establish whether really they had fibrosis, did they benefit? So we might have to look at follow-up and all, which we have really not looked into. But as a benefit of doubt, selected patients we have used, and we are yet to come out with the results and the follow-up.
Got it. Okay. I think we are in the last half an hour, so we should start taking some of our audience questions now. And there are some questions coming in. I'll direct the first question specifically to Dr. Sandeepa. This is from Mr. Dr. Abdul Rahim. He asks, would you say that post-COVID fibrosis should be radiologically reassessed with a second CT thorax after 3 months? What about a patient who was mechanically ventilated for, let's say, 2 weeks with ARDS or with severe pneumonia with sepsis? How to assess those patients' lung function apart from a serial X-ray or a pre-discharge spirometry?
See, I would say, again, first thing what you have to do is, you have to see how your patient is doing clinically. As compared to at the time of discharge, if he's coming at the end of 15 days follow-up and is slightly better, that is sufficient enough evidence for me to believe that his underlying lung condition is improving. We need not objectively measure and keep everything because it is a pandemic and it is an unnecessary thing, unnecessary burden on the patient. Okay. So if you ask me, if a person getting ventilated for 2 weeks and then getting extubated itself is the greatest thing. I think Gauri Shankar should add to this. How many of our patients who have been ventilated for 2 months, 2 weeks on a ventilator have come out of a ventilator? Okay, maybe even if it is 1 or 2 patients, okay, then he will take a slightly longer duration of time to come out of his underlying disease. Okay, that you keep it as a, a special case. Okay, so we have to see it as a special case only. When it comes to generalized things, why do we need a spirometry? Why do we need a CT scan? When the saturation is fine, when the patient is clinically fine, what do we need to document for the sake of documentation is my question. Okay, so if at all your patient is clinically doing well, if his saturation is improving and is responding with the time, and every follow-up is coming to you, and if he's doing well, I don't think we should do any kind of test. Just leave him alone, give him confident words, reassuration, and maybe at the end of 3 months, if you're still keen on assessing how his lung functions are, I would say at least 3 months gap should be given. Okay, for the process to settle, the healing process to settle, and then maybe at the end of 3 months you can have that as a baseline, and maybe follow him up with after 3 months with another PFT if this PFT is still showing some restriction, and compare it with the latest PFT which is going to happen after 6 months. Otherwise, I have been very, very conservative and very calm and peacefully watching my patients recover back to their normalcy, definitely over a period of time. So I have not ordered any kind of test to assess his lung function. My simple assessment is based upon pulse oximetry, maybe a 6-minute walk test, or if he is not able to walk for 6 minutes, let him walk for 3 minutes and come back to me. I will see if there is no drop in saturation, or if the recovery time from the drop in saturation is improving with the with every follow-up. That itself is a reassurance for me to tell that his lungs are coming back to normalcy. I have not asked for any spirometries in my patients because I know it is, I don't know, I mean, till what extent it might be beneficial, because it is again, it is a healing process. The healing takes time depending upon the initial damage. So people who have got an initial higher damage will take slightly longer time to recover, and I have waited patiently for them to come back to normalcy rather than, investigating them to assess the function of the lungs, either in the form of spirometry or in the form of CT scan. Maybe I might look after DM with a slightly old school thought, but this is what we have been doing. Not only me, our entire center is doing that, and we have achieved reasonably equal results as compared to any other center.
Great. This next question is a very interesting question. In home isolated patients who have COVID-19, are there some red flags that would indicate the initiation of either anticoagulants or antifibrotics in such patients? Dr. Gauri Shankar, would you like to take that as a question?
In home isolation, home quarantine, the situations or thresholds of home quarantine, if I may discuss it in a bit detail, have changed when it compared to first wave and second wave. The patients who got beds in the first wave really did not get a hospital bed in the second wave. So there was more of a resource constrained situation when we say home quarantine. Most of our patients who did require a hospital bed, we did treat them at home because of this situation. So, but looking at the requirement of anticoagulation, so as we know that COVID is a prothrombotic state, so we have seen elevated D dimers, though they may not correlate with the actual situation of prothrombotic state, but in general, as even Dr. Suryanarayan told, higher incidences of stroke, higher incidences of ischemic events. So the threshold to start anticoagulation therapy has decreased. So there have been teleconsultations, sometimes on OPD basis also. A few of my colleagues I have known, they have prescribed anticoagulation looking at the high risk category of patients, what comorbidities they have, the severity of disease. And when I mean the severity of diseases, it is not about severe hypoxia. It might be a mild requirement of oxygen, 1 or 2 liters. Then there could be deranged lab values like D dimers rising, more than 2 times at least, to up to 5 times. In this category of patients, people have, we have started anticoagulation at home. Again, coming down to antifibrotic agents, the complications or the adverse events or the ease of use when you compare anticoagulants and antifibrotic agents, people are scared of using anticoagulant agents because of the risk of bleeding. But in the case of antifibrotic agents, not many adverse events people have witnessed, may it be the bleeding or hepatotoxicity. So in the initial phase, we have seen people prescribing antifibrotic agents also, which I feel would not be necessary. And personally, I would not recommend. But if again, there are a set of patients with lung diseases, previous history of or risk factors for fibrosis, or evidences of pulmonary intravascular thrombosis, like, as you say, some rise in pulmonary pressures, pulmonary hypertension, we might as well start them, not in the context of not to lose the precious time. So,
got it. I think that's
yes. I think, see, as far as the anticoagulation is concerned, I think everybody should be on anticoagulation, no doubt about it. The moment they are diagnosed to have COVID or they are suspected to have COVID, because coagulation abnormalities are the major cause for death and complications in COVID. No doubt about it. Every person who is diagnosed to have COVID or he is suspected to have COVID, there is no harm in putting him on one or the other anticoagulation, because we are anyway using a prophylactic dosage, not as a therapeutic dose. Okay, for that matter, all patients of COVID have to, because we don't know, to be frank, see, everybody tells who are the risk factors, these are the high risk patients. Who are those high risk patients? See, is their diabetes is directly correlated? No, we are seeing a lot of young people without any comorbidities, without any abnormal lung diseases or without any underlying lung disease, getting equally affected as the people who are having comorbidities. See, to be frank, the data is not very clear on who is going to progress and who is not really going to progress. Although from our experiences, I would say male sex is something which is very, very notorious to progress. Above 30 to 60 is the age groups who are going to be very much, who have got a very higher chance of progression into respiratory failure kind of a picture. And they are the ones who can develop these thrombotic complications. So as a blanket therapy, unless there is a high risk of bleeding, maybe an elderly 85 years or 90 years old who has got a high risk of some intracranial bleeding, if you start him on anticoagulation without monitoring, they are the ones whom you have to consider, to keep them devoid of anticoagulation. Otherwise, everybody should receive anticoagulation, no doubt about it.
Okay, great. Thank you. A question for all of you all. This is a very interesting question. How do you rate rivaroxaban as a drug of choice for anticoagulation? And how do you titrate or choose between the doses of 10, 15, 20? So anyone who wants to take it.
Sharma sir?
Yeah. Rivaroxaban, see, first thing is if patient has a renal dysfunction, creatinine clearance we check. If creatinine clearance above 50, generally we give full dose of rivaroxaban. If creat clearance between 30 to 50, we will reduce it by 25%. And less than 30, we reduce to 50% of the dosage. And again, whether our intent of treatment, whether it is therapeutic or prophylactic. If it is prophylactic, we can actually go slow. As Dr. Sandeep mentioned rightly, we can start either 10 mg once a day or maximum 15 mg based upon the body weight. If we are targeting on the therapeutic therapeutic target, then definitely you hit them hard with either 20 mg twice a day or 15 mg twice a day based upon the body weight and creatinine clearance. Yeah. And coming to the choice of rivaroxaban over other two anticoagulation, definitely if you see from the neurologist standpoint, trials have shown that there is a slightly increased risk of bleed compared to other two anticoagulation. But here we are talking in a COVID scenario. See, COVID scenario is slightly different because patient didn't have any cardiac risk or any other risk. So definitely, I would say that if patient has mild renal dysfunction, mild to moderate, we can definitely consider rivaroxaban over dabigatran. Dabigatran, why we are so confident about it is because we have been using it for more than almost 10 years. So everyone has that confidence, and even guideline and data has come. But rivaroxaban and apixaban also we have used in quite a lot of patients with minimal, I can say, I have not seen any life-threatening bleed with rivaroxaban as of now. I'm sure about my other two panelists also. So, let's be practical. What Dr. Sandeep is trying to tell is, we will be practical to that particular patient. Number one, we will try to reduce the cost of treatment. We will not create unnecessary panic. See, I don't give a choice. I don't tell a patient, you take rivaroxaban or you take apixaban or you take dabigatran. These are the advantages, these are disadvantages. Who are they to decide all that? It's me. I will tell, fine, you take rivaroxaban. Next patient, you take apixaban. Next patient, you take dabigatran. You randomize on your own patient because you have a huge patient load actually to do that. So we can do it. And I have done that and we have been quite successful. So my opinion is, if renal dysfunction is there, please definitely consider rivaroxaban as a better molecule compared to others. But in all other conditions, I feel we can safely use all the molecules.
Okay, great. Thank you. Dr. Sandeep, would you
say? We have been using rivaroxaban 10 mg OD as a prophylactic thing.
Okay, 10 mg OD.
Yes.
All right. So that's helpful for our audiences to hear. This next question is that I think some of these we have answered. Somebody has asked, do we have to start antifibrotics for all potential COVID ILD so that they don't turn to fibrosis? I think we've discussed that not everyone needs it. Certain criteria, parameters, only then those need to be followed and tracked. There's a question about shifting patients from pirfenidone to nintedanib. Is there any advantage, disadvantage? When do you consider using one over the other? Anyone would like to take that? Yeah,
I'll answer that. See, basically, vis-a-vis, if you compare pirfenidone and nintedanib, all the studies have been done when with respect to idiopathic pulmonary fibrosis.
Right.
Okay. So nintedanib has been proven to be equally efficacious as pirfenidone because pirfenidone was an earlier molecule. Okay. Now we are using here in a different context. See, here different context in what sense? Because we are using it for the prevention of fibrosis in a COVID viral infection. Okay. So now here the patient is already on too many drugs. Okay. We have to choose a relatively safer drugs. As compared to pirfenidone, nintedanib is on any day much more safer as compared to pirfenidone on any day when it comes to side effects. Okay, there are hardly any side effects is associated with nintedanib other than some GI upset like diarrhea and all those things. It is hepatosafe, it is renal safe, and the dosage also. See, the dosage of pirfenidone, what has been used in IPF is somewhere around 2,400 to 3,200 milligram. And achieving that much with the existing, pirfenidone, preparation is difficult. So given a choice of antifibrotic, definitely nintedanib will stand far ahead as compared to pirfenidone. No doubt about it. Because it is safer drug. It has got, the pill burden is extremely low. And it is shown to be equally efficacious as compared to pirfenidone. So on any day, If at all you have to put him on an antifibrotic, nintedanib would be the first choice.
Got it. Dr. Gauri Shankar and Dr. Suryanarayan, would you also, more so for Dr. Gauri Shankar, do you agree with that? You feel that that's how you all have also used it in practice?
Yeah, absolutely. Nintedanib has been the choice, especially in settings of renal dysfunction where parfenadone has been found to have some adverse renal side effects that we have seen. Also, it is not used in low GFR conditions. Nintedanib, though we say has some bleeding risks, but we haven't seen any as of now attributed to it, and we have been using it safely. Yeah.
Any concern with using, this is another question that has come more than once, any concern with using nintedanib and rivaroxaban together in a patient? Because both can be associated with a little increased risk of bleed. So any concern there if you're using the standard dosages?
I don't see it.
As again,
Not any kind of bleeding complications when we have been used. I don't know. I think Shankar or Dr. Sharma, if you can add something. Sharma will not be able to. Gauri, you can add something.
overall, if I say as such, the bleeding complication itself has been not very high in my ICU. I have seen hardly 1 or 2 bleeding cases in severe COVID disease that we attributed to DIC.
Okay.
The picture was such, but not per se to rivaroxaban. Rivaroxaban we have not used in the ICU. We have used enoxaparin or parenteral preparations. So both together, usage of both together, we haven't done. But yeah, nintedanib separately when we used, we did not find any bleeding risks. And for rivaroxaban also, I think hardly anybody has come up in the follow-up as with having some bleeding complications. I don't remember any. Yeah.
So I think overall the message is clear that if you're sticking to the standard prophylactic doses or the standard dosages, they're both safe and they can be combined.
Yes, they can be combined.
We have one question on the dosage of rivaroxaban in chronic liver disease. Any adjustment needed there?
Yeah, definitely. If hepatic impairment, they suggest in mild to moderate hepatic impairment, they suggest 50% dose reduction.
Okay, all right.
Yeah.
There's another interesting question. Antidote for rivaroxaban, I'm assuming they want to say overdosage. If someone is on too high of a dosage, how do you reverse if they are having problems? So I don't know whether they mean overdosage as an acute overdosage or someone who should have been on 10 and was on 20 BID. If they come in with a problem, what do you do to reverse it? So any thoughts on that? Though the question is not very clear.
FFP is the best antidote. That's all.
I would also add on to that. There have been antidotes referred to like idarucizumab and then Nexet alpha. But what we have used is also prothrombin complex concentrates around 4 units that would be helpful to reverse if at all there is any over usage of rivaroxaban.
Okay.
For dabigatran,
apixaban and rivaroxaban with subcutaneous bleeding and all. I think we have just stopped the drug and started them on FFPs after consulting the hematologist, and most of them have got stabilized.
for dabigatran, we have a specific antidote. That is, as Dr. Gauri Shankar was mentioning, idarucizumab. But for apixaban and rivaroxaban, yes, there is no definite, antidote as such, but we can manage with FFP.
Okay, great. All right. Will there be a place for remdesivir in the new variant challenge if there is a third wave, or in the midst of all these other drugs and options that are coming out? Will it not be relevant? We have not spoken much about it, but it is an important part of our treatment plan. So anyone's thoughts on the role of...
I would say, basically, I think, I don't know why data is not supporting the usage of remdesivir. As a treating physician, we have all experienced, if it is given at the right time. Again, time is very, very important. See, in treating COVID, we should know the timelines. So in a viral phase, any form of antiviral will have some or the other advantage. There is no doubt about it. If you start remdesivir after 6th or 7th day, I don't think it is going to add anything to the advantage of the patient. But definitely, if the patient comes to you early, and if you are in a position to start the patient on remdesivir, I would still say how many n number of variants might come. Remdesivir is a broad spectrum antiviral. It is just like using a broad spectrum antibiotic we use for this piperacin, tazobactam, the meropenem and all. We are using broad spectrum antibiotics, no, just to cover the probable organism because it has got a wide coverage. Similarly, when you are dealing with the viral disease and you know that it is a broad spectrum antiviral and it might add some advantage in the form of an antiviral, I think there should not be any hesitation in starting them on remdesivir. But timing again is important. Within first 3 to 4 days, if you start the patient on antivirals, definitely the inflammatory phase is definitely going to be less severe, is what is our belief as well as experience. Although we don't have the supporting evidence to show it, because we were too much occupied with these number of patients, we are not able to provide the data. But somehow, as a qualified pulmonologist, I still feel remdesivir has got a good role, provided if it is used at the right time in the right person.
So I think as an RD and RP inhibitor, that it can really work as an antiviral. I think everyone agrees that it has a role. And again, the key is before day 10 of illness. So I think starting, as you said, from day 3, 4 up to day 5, 6, if it is begun, then there is a better role. Starting it too late, we all know we are outside the viral phase and we are into the inflammatory phase where it will not show much benefit. But sometimes even in those phases, because we realize some patients can have a prolonged viral inflammatory phase. So I think that as a clinician, that's a judgment each one needs to make, but there is definitely a role. Any role for any experience that you all have with the antibody cocktails? There's a question about that in the management of COVID-19.
See, antibody cocktail again here, and we have also used for 2-3 patients. Okay. And if given early, definitely all 3 of them have gone back home without getting any kind of complications. See, just to use it as a blanket therapy in our patients is something which we have to think about, because we are in India and most of our patients have got only issues with affordability. And the government, I don't know, it is not yet included that in its regimen. So definitely role is there, evidence is there, people are already using it. We have also used it, not in all patients, 2-3 patients only, and who are affordable, who are insisting us upon using that. Okay, because they had some relative in America, they wanted them to be started on antibody cocktail. We have used it. Even one patient was post liver transplant. Actually, we have used antibody cocktail. Definitely, it is all 3 of our patients have survived. The question is how affordable it is for a common man. Okay, that is very, very important. And if we think that there are other viable options which can be used instead of those antibody cocktails, definitely the role of antibody cocktail is there. I cannot negate it, but how effectively we can use it in all our patients is still a question.
I think the indication of being in mild to moderate disease and being able to prevent the progression, I think, is an advantage. And like you said, if the right situation with the right affordability, if it can be used at the right time, it can make a difference to the clinical picture.
Definitely.
Any thoughts on the baricitinib? Have you all?
Yeah, we have used baricitinib, and there is also an NEJM publication of baricitinib with remdesivir standing ahead of remdesivir alone therapy. So on the similar lines, even tofacitinib. So we have had chance of using both of them, and I would say that without a publishing data, there have been better outcomes with baricitinib and tofacitinib.
Okay, great. I think that's reassuring. So we certainly are a long ways ahead in terms of having multiple options for treatment now, especially in the mild to moderate cases, and not letting them progress to the severe situation, where then we'll be talking about post-COVID complications, including coagulopathic, neurological, cardiovascular, pulmonary, and all those. So I think we are definitely way ahead of where we were a year and a half ago. I think we have covered most of the key questions that have come in. There is one question that I would like to take. I think this is a relevant one that has just come in. What should be the minimum and maximum duration of nintedanib treatment, and on what basis should that be decided if someone is started on it? What is the minimum duration that you would use, and what is the maximum duration that you would use? Either Dr. Sandeepa or Dr. Gaurishan. I know it's a tricky question, but
Again, see,
your practical approach,
what we have been doing is at the end of 2 weeks, as Gauri Shankar said, I think we start them on antifibrotics. The moment we feel that the saturation is back to normal and the patient is doing well and his 60-minute walk test is not showing any kind of desaturation, I would stop it at that juncture.
Okay. So you would not say, because I've heard other pulmonologists say that, a 3-month duration seems to be a...
On what basis? On what basis?
Okay.
On what basis have you decided 3 months? Again, that is a question mark, right? See, we are again in the zone of ifs and buts. I think, see, COVID, everything has been put on to fast track. We don't have randomized controlled trials, level 1, level 2, level that kind of evidence. Whatever we are practicing is all, individual experiences and short-term duration studies. Okay, so I have limited hours. Most of them we have extended it up to 3 months. Okay, so I would rather put it in this way rather than fixing it up for 3 months. If the patient has come back to his normal, what is our intention to treat is to bring the patient back to normal saturation, isn't it? Once we have achieved that, I think there is no point in continuing the antifibrotic. Okay, majority of the time it might take 6 months, 3 months. I don't deny it. But rather than keeping 3 months as a landmark, I would like to keep a more practical approach in this way. If it takes for 5 months, we have to extend it up to 5 months. And if it takes less than 2 months, then we can stop it at 2 months.
Yeah, absolutely. Adding on to the same, Dr. Sandeep, I agree absolutely. So people who are requiring, say, home oxygen or requiring 1 to 2 liters, 3 liters, or who have severe lung changes might require, not all patients as an empirical blanket therapy.
No, clearly we are not talking of an empirical blanket. We are talking about people who actually need it. What is the average duration of use, minimum, maximum? And I think from what Dr. Sandeepa has also said, it seems like the average duration is about 3 months, but it may be shorter if they get better faster. We clearly understand that, and it may be longer also if they are not showing the speed of recovery.
Yes.
I think we have covered most of the key questions, and we are also on time. It's 9:02 now. We've completed our timeline. I would like to really thank all three of our panelists for a fabulous discussion. I think we've given a lot of practical approach tips to our audiences, and hopefully these will be useful to them in their day-to-day practices as we go ahead and manage this, what I would call ever evolving and ever teaching us disease. We have learned a lot in the last year and a half that we didn't through any of our microbiology or pharmacology or any of those courses, because there's a lot to real life that is unique. A very special thanks to the Hetero Healthcare team, Pallavi, Mr. Shailesh, Mr. Shastri. Appreciate you all organizing these webinars and bringing updated knowledge from wonderful specialists on our panel to the audiences. And again, a very big thank you to all our panelists for being here this evening and sharing your expertise and experience with all of our physicians. Everyone take care, stay safe. Jaan hai to jahan hai. Take care of yourself first. Everything else comes next. So with that, over to you, Pallavi.
Thank you, sir. Thank you so much for such an insightful discussion and sharing your in-clinic experience with us and with our audience tonight. Thank you so much. Thank you, sir.
Everyone have a blessed
Thank
day.
you.
Thank you.
Thank you.
Sitish, it was
Bye.
wonderful moderation. I think you have covered almost everything. It was
Thank
very
you.
nice
Thank
from you. So
Thank you.
thank you, Pedro.